I think we have this tendency to um, treat human anatomy like it's this static architectural blueprint. Like you look at an anatomy textbook and you see the walls, the hallways, the plumbing, and you just assume, well, that's how the building is constructed.
Right, like it's just fixed and unchangeable.
Exactly. But today for this deep dive, we are going to completely shatter that static blueprint idea. Welcome to the deep dive, by the way. We're so glad you're here. We are diving straight into this really fascinating intersection of biomechanics, embryology, and neuroplasticity.
Yeah, it's a really incredible topic.
It really is. We're looking at how a congenital short vagina structurally limits penetration depth. And this is the really actionable part. What specific mechanical angle-based adjustments can bypass deep pelvic pain?
Because the human body is, it's highly dynamic. And when that standard blueprint changes during fetal development, the physical rules of how that body interacts with the world, well, they have to change too.
We're really looking at the why behind the human body today, which is what I love.
We aren't just exploring the what of the condition, we're really examining the physics of tissue, the central nervous system's threat response, and how manipulating spatial angles literally rewrites physiological boundaries.
Okay, let's unpack this. Because the origin of a congenital short vagina is just so fascinating when you look at it purely from an embryology standpoint.
It really is. I mean, to understand the mechanical limits, you have to understand the architectural baseline first.
Right, so let's start there. What happens during development?
So during the 5th or 6th week of gestation, typical development relies on these structures called the Mullerian ducts. They're these bilateral ducts that are supposed to grow downward and basically fuse together at the midline.
And they form the internal organs, right?
Exactly. They form the uterus, the cervix, and the upper two-thirds of the vagina. But in several distinct congenital conditions, that fusion it halts mid-process. And the most common one is Mayer-Rokitansky-Kusterhauser syndrome, or MRKH.
Okay, MRKH. And at MRKH, we're looking at a typical 46XX karyotype, right?
Yes, exactly.
So the ovaries are fully functioning, and the endocrine system still pushes the body through a totally typical puberty for a female.
That's right. You have functioning ovaries, typical hormonal cycling, normal external genitalia. But internally, the Mullerian agenesis means the uterus and that upper vaginal vault, they just never formed.
Which is wild to think about.
It is. Now, compare that to complete androgen insensitivity syndrome, or CS, which presents this very similar structural outcome, but through a totally different genetic pathway.
Ah, right, because CIS is genetically male, isn't it?
Yeah, CIS involves a 46XY karyotype. The genetic markers are male, but because the body's androgen receptors are entirely non-functional, the tissues literally do not respond to testosterone at all.
So the body just defaults to a female physical phenotype externally.
Right, externally it does.
Right.
But because the fetal tests are still in there producing anti-Mullerian hormone, the Mullerian ducts are actively suppressed.
Oh, I see.
So again, you end up with typical female external genitalia, but no uterus and no upper vagina. The structural reality for patients with either MRKH or CIS is that instead of a typical vaginal canal measuring, anywhere from 6 to 12 centimeters in resting depth.
You just have a shallow space instead.
Yeah, they present with what's called a vaginal dimple or a blind pouch. And that usually measures only 1 to 4 centimeters deep.
Which fundamentally changes the mechanics of sexual intercourse. I mean, we look back at the foundational research by Masters and Johnson on typical sexual arousal.
Oh, their work on the physiology of arousal is incredible.
It really is. They documented this massive architectural shifting inside the pelvis. During the excitement and plateau phases, the body undergoes a process called tenting.
Yeah, the biomechanics of tenting are just remarkable. As vasocongestion builds, which is basically just blood flowing into the pelvic region, the smooth muscle of the upper vagina relaxes and expands.
It basically balloons out, right?
Exactly. The entire upper vault lengthens by like 3 to 4 centimeters and balloons outward. And simultaneously, the uterus elevates up into the false pelvis.
So it's essentially like an internal reorganization to clear a pathway.
That's a great way to put it. That elevation pulls the sensitive visceral structures, things like the posterior cul-de-sac of Douglas and the ovaries. It pulls them up and out of the line of fire.
It creates a buffer zone.
Yes, exactly. The vaginal canal is essentially a potential space that actively accommodates penetration. But in someone with a congenital short blind pouch, the biological lengthening and elevating, it simply cannot happen.
Because the structures just aren't there. It's like a hallway where the back half just hasn't been built and the walls don't magically expand to make room when you open the front door.
That's a perfect analogy. The physical structures required for that expansion are entirely absent.
I really want to pause on that mechanical reality for a second. If you're dealing with a 1 to 4 centimeter pouch, and that space physically lacks the tissue to accommodate expansion,
Which it does, yeah.
what exactly happens at a cellular and structural level at the apex of that pouch when penetration is attempted? Because the space physically isn't there.
Right. And that collision is the root of deep dyspareunia or deep pelvic pain in this patient population. Because the vaginal canal is a short, blind ending, penetration literally strikes a physical wall.
A literal wall of tissue.
Yeah, and we aren't just talking about regular skin here. Without the natural buffer of an expanding upper vault, the mechanical thrusting transfers kinetic energy directly into the pelvic peritoneum.
That's the sensitive membrane lining the abdominal cavity, right?
Exactly. And depending on the specific layout of the patient's internal organs, this can mean blunt force pressure directly against the ovaries or even the bowel.
Ouch. I mean, hitting visceral tissue repeatedly with that kind of force isn't just going to cause mild discomfort. That's going to trigger a massive neurological alarm.
Oh, absolutely. What's fascinating here is that it kicks off this whole cascade of sympathetic nervous system responses. The pudendal nerve and visceral pain fibers, they immediately signal the central nervous system that a traumatic injury is occurring.
But wait, I'm struggling with the timeline here a bit. Let's look at the nervous system's response. Does the brain learn to trigger pelvic guarding after just one distinctly painful encounter? Or is this hypertonic muscle state something that, builds up over years of silent, agonizing attempts at intercourse?
Well, it varies from person to person, but honestly, the central nervous system is a highly efficient prediction machine. It doesn't need decades to learn a threat.
It figures it out fast.
Oh, yeah.
Mm.
Often, just one or two severely painful attempts at penetration can establish a powerful neurological feedback loop. The brain starts associating the environmental cues of sexual intimacy with visceral trauma.
Wait, so the pain isn't just about the physical wall being hit. You're saying the brain actually anticipates the pain and triggers the muscles to actively fight back by tightening.
Exactly. The brain sends a signal to the levator ani muscles, which is basically the pelvic floor hammock, commanding them to lock down to protect the internal organs.
Which then makes the space even smaller and more painful.
Precisely. It's a reflexive, hypertonic muscle spasm closely related to vaginismus. And look at the physiological domino effect here. The fear of pain spikes cortisol and adrenaline, which actively suppresses the parasympathetic nervous system.
Which you absolutely need for arousal.
Right. You lose the physiological arousal, which means you lose natural lubrication. And the lack of lubrication dramatically increases the friction coefficient, making the physical collision even more painful.
Which in turn reinforces the brain's prediction that sex equals trauma.
Exactly. The pelvic floor clenches even tighter. It is a compounding, self-perpetuating loop of physical compression and neurological guarding.
Knowing that mechanism perfectly explains why the old school advice to just, relax and push through it is not just unhelpful, it's biologically destructive.
It's terrible advice. Pushing through it just reinforces the trauma code in the brain.
Right, because you cannot willpower your way through a structurally capped biological wall and a hyperactive nervous system alarm.
You really can't. Treating this requires abandoning brute force entirely. If the depth is structurally capped, we have to respect the physical boundary and manipulate the physics of the encounter instead.
Okay, let's talk about those physics, because this is where the medical literature gets really cool. The work from the UNC School of Medicine, specifically Dr. John Steege and Dr. Dennis Zollner, is fascinating here.
They've done great work on this.
They outline specific biomechanical workarounds to completely bypass that deep pelvic pain. Because if you can't increase the depth right now, you have to control the angle and the limits of penetration.
Yeah, they advocate heavily for positional adjustments that grant the patient absolute mechanical control. And they usually start with the crosswise position.
How does that work exactly?
Well, this isn't just about comfort, it's about pelvic floor neurology. In the crosswise position, partners lie perpendicular to each other, like an X. The critical biomechanical factor here is that neither person is utilizing their core or their limbs to support their body weight.
Oh, I see. Which means the pelvic floor doesn't have to engage as a stabilizer.
Exactly. When you are holding yourself up, like in a plank or lining over, your pelvic floor muscles naturally contract to maintain intra-abdominal pressure and core stability.
That makes total sense.
By lying completely supported across each other, the levator ani muscles can remain in a flaccid, relaxed state. Plus, this geometry leaves the external genitalia completely accessible while physically limiting the forward trajectory of the penetrative partner's pelvis.
Here's where it gets really interesting. It's like parking a car in a really short garage, right? You can't just keep driving forward hoping the garage gets longer.
Right, you'll just crash.
Exactly.
Yeah.
If you have to park at an angle or put a parking block on the floor so you stop halfway, you're artificially capping the momentum. The person with the shorter vaginal canal can dictate the exact angulation of the hip hinge.
And if a specific angle sends pressure toward a sensitive area of the peritoneum, they can microadjust instantly without having to fight gravity.
Because gravity is a massive factor, isn't it?
It's huge. This is why the woman on top position is also clinically highlighted. By placing the patient with the structurally short vagina on top, you harness gravity for control, rather than letting it dictate the force of penetration.
So the penetrative partner is stationary.
Right. Meaning the downward kinetic energy is 100% regulated by the patient. They can physically halt the downward motion millimeters before it hits the painful apex.
I also noticed the clinical guidelines discussing spooning with closed thighs.
Yeah, that's another really effective option.
Because if internal penetration is triggering too much guarding, or the pouch is simply too shallow, closing the thighs and utilizing lubrication allows a partner to simulate the friction of penetration externally.
Which is great because you bypass the structural limitation of the vaginal canal entirely.
Exactly, while still maintaining clitoral stimulation, which, neurologically speaking, is where the vast majority of the pudendal nerve endings responsible for sexual pleasure are clustered anyway.
Exactly. These are immediate, cost-free mechanical shifts. They alter the dynamic from a state of unpredictable visceral collision to a state of predictable safety.
And the central nervous system needs that predictability.
It does. It needs it to stop sending the guarding signals. But, as effective as these spatial adjustments are, they are ultimately workarounds for a fixed boundary.
Right. So what if changing body positions is just the immediate fix? What physical tools or long-term structural changes can be made to actually increase that depth? The literature also provides pathways for patients who want to physically change the boundary itself.
Yeah, we are moving from adjusting the angle to actually physically remodeling the tissue. Let's look at the physical tools that bridge this gap first.
Like the parking blocks from my garage analogy.
Exactly. If you want to engage in penetrative intercourse without constantly mentally calculating depth and angles, how do you artificially create a buffer? One of the most effective clinical tools is a device called the O-nut.
Oh, nut. How does that work?
It's a series of soft, stacking polymer rings that are worn at the base of the penis or on a penetrative toy.
So they literally act as a physical stop-loss.
Yes, they function as a compressible shock absorber. By stacking these rings to the exact depth of the patient's vaginal pouch, the penetrative partner's pelvis will physically hit the polymer rings before the tip of the penetration can strike the apex of the vaginal blind pouch.
Wow, so it outsources the depth control to a physical tool, which means the brain can finally stop obsessing over it.
Precisely. The patient doesn't have to anticipate the pain because the polymer rings make hitting the wall physically impossible.
It allows the parasympathetic nervous system to finally take the wheel.
It really does. But if the ultimate goal is to permanently increase the depth of the anatomical space, we turn to the gold standard, the first-line treatment recommended by the American College of Obstetricians and Gynecologists.
And it isn't surgical intervention, surprisingly.
It's not. It is non-surgical vaginal dilation.
Okay, this is where I really need to unpack the mechanism, because the literature refers to this as the Frank method, developed way back in the 1930s.
Yeah, it's been around for a long time.
The process involves applying gentle, consistent pressure to the vaginal dimple using smooth, medical-grade tubes called dilators, right, for 10 to 30 minutes a day over several months.
That's the standard protocol, yes.
But I want to challenge the word stretching here. When I think of stretching skin, I think of a rubber band. You pull it, it stretches. When you let go, it snaps back. How does applying pressure for 20 minutes a day result in a permanent 6-centimeter anatomical canal?
It is a brilliant question, because stretching is actually a total misnomer. What we are really talking about here is mechanotransduction.
Mechanotransduction, the cellular response to mechanical load.
Exactly. When you apply consistent, targeted physical pressure to the epithelial and connective tissues at the apex of that dimple, you are creating mechanical tension.
And the body senses that.
It does. The cells in that tissue, specifically the fibroblasts, they literally sense that physical tension.
They interpret the physical pull as a chemical command to remodel.
Yes. The tension triggers a cellular signaling cascade. The fibroblasts begin synthesizing new collagen and elastin fibers. They're actively laying down new extracellular matrix.
Oh, wow.
Yeah, you aren't just stretching existing cells, you are commanding the body to undergo cellular proliferation. The tissue is actively growing new cells to accommodate the structural demand.
So it's basically orthodontics for soft tissue.
That's a great way to think of it.
Just like braces apply constant tension to move a tooth through solid jawbone by forcing the bone to break down and rebuild, the dilator is forcing the vaginal tissue to generate new structural architecture.
That is the exact physiological mechanism. The patient starts with a dilator about the size of a slender tampon. They hold it against the dimple at a downward angle, following the natural curve of the pelvic floor.
Okay.
And as the mechanotransduction triggers cellular growth over weeks and months, they graduate to wider and longer dilators. A 1 to 4 centimeter pouch can genuinely remodel into a functional, highly elastic canal of 6 to 8 centimeters.
That's incredible. And ACOG cites a success rate between 90 and 96% for this method.
That's highly effective.
But surely this cellular remodeling isn't happening in a vacuum. I mean, what about that hyperactive nervous system we talked about earlier? If a patient is applying pressure to an area the brain has already coded as a trauma zone, how do they keep the pelvic floor from locking down and fighting the dilator?
And that is exactly why the protocol for dilation requires immense patience and emotional readiness. Dilation isn't just physical, it is a dual therapy.
Meaning what?
It is mechanotransduction for the tissue and progressive desensitization therapy for the central nervous system.
So what does this all mean for the patient? Are they essentially doing physical therapy for their anatomy, A&D, their nervous system, at the exact same time to permanently change their structural limits?
Yes. You are overriding the neurological alarm code in real time. Because the patient is in complete control of the dilator, they are in a safe, private environment. If they feel pain, they stop.
That seems like a really important distinction.
It's vital because pushing through pain during dilation completely defeats the purpose. If it hurts, the sympathetic nervous system fires, the pelvic floor muscles lock down, and the dilator is just pushing against a rigid muscular wall instead of signaling the soft tissue to grow.
The therapy only works if the brain allows the tissue to remain compliant.
Exactly. By maintaining a pain-free threshold, the patient proves to their own nervous system day after day that pressure in this region does not equal trauma.
The brain slowly downregulates the threat response.
Right. The pelvic floor learns to coordinate a relaxation reflex rather than a guarding reflex. You are rehabilitating the anatomy and the neurology simultaneously.
To bring this all together for you listening, because I know this can feel like a lot of heavy medical jargon, the big takeaway is that painful sex in this context isn't some mysterious, untreatable failing of the body.
No, not at all.
It is a highly logical, structural collision. You have a physical boundary, and when that boundary is breached, the nervous system acts exactly as it is designed to act. It throws up a defensive wall of muscle.
But because it is a mechanical issue, it responds beautifully to mechanical solutions.
Exactly.
Whether a patient chooses to manage that boundary through the physics of the crosswise position, or implement a physical buffer like the ONUT, or, commit to the biological remodeling of the Frank method, the core strategy remains the same.
Right. You shift the environment from an unpredictable threat to a state of calculated control. You respect the biomechanic.
And you utilize the body's natural capacity to adapt. The tissues and the nerve pathways are not fixed. They are literally waiting for the right mechanical inputs.
Which leads to a really fascinating implication, I think. We've spent this deep dive unpacking how targeted, consistent pressure mechanotransduction can command the body to build entirely new, functional anatomical space while simultaneously rewiring a deep-seated neurological trauma response.
It's pretty amazing.
It is. If our bodies possess that level of localized adaptability, think about the broader applications. I mean, this exact science of cellular signaling via mechanical tension is currently being studied to rehabilitate severe burn victims, to force restrictive, rigid scar tissue to remodel back into pliable, healthy skin.
It really changes how you view tissue regeneration.
It does. If we can literally overwrite structural boundaries and nerve alarms through nothing but directed physical pressure and mental relaxation, how much of what we consider permanent physical trauma is actually just tissue waiting for the right mechanical command to rebuild itself? It really makes you question what the true physical limits of the human body are. Keep that in mind.